Hi everyone, I'm Debs. I'm a consultant cardiologist at Barts Heart Centre and the clinical director for cardiology at Whipps Cross, also the creator of Ortus. So um, we've had a lot of experience in remote monitoring, and the two examples that we've had so far is really, I think, an exemplar of secondary care and then primary care, and then hopefully how we can join the two up. I'm going to talk about our kind of experience at Barts. Um, we've got a heart failure virtual ward that was set up and working quite very well. Our aim is to create a kind of a heart failure long-term remote monitoring, but the evidence base for that is still challenging on engagement. From an Ortus perspective, we also remotely monitor the entire cardiac surgical wait in London for deterioration, and we know this long-term remote monitoring takes quite a bit of engagement. So our next challenge really was when Strong HF came out and said, we need to rapidly up titrate patients in 6 weeks. And we thought, God, how the hell are we going to do that? From our audit data, we know we do that very poorly already in 6 months to a year, if at all. Forget 6 weeks. So clinicians and consultants are becoming more fait with asynchronously managing cases, meaning things like advice and guidance, where we get some information from our colleagues and just tell our colleagues what to do. And one of our thought processes, one of our thought was, well, can we manage that in the same way, a kind of a rapid up titration clinic? Ortus allows you to get not only your blood pressure, your heart rates and symptoms, but quickly message patients back with quick clinical letters, and using the tool you can prescribe and write what medications they're on, so you can track their medications through the platform. So this was the first pilot that we presented at the European Society of Heart Failure this year. We put 39 newly diagnosed heart failure patients through our rapid asynchronous up titration clinic. What does that mean? They were all given access to the software. If they didn't have a blood pressure, which only 2 out of our intervention group didn't, we would give them that. They were then given one phone call to explain the pathway. Then a subsequent, in 6 weeks, 8 asynchronous appointments. What that meant was that they were told to expect twice a week, on a Tuesday and a Thursday, a letter and a message from us telling them what to do with their medications. They will get one final phone call where we would offboard them. We then tracked 12 patients who we, as our control group, just to see what were the differences. Now, we in our cohort, 0% had 30% kind of 30-day readmissions. We had an 18.2% improvement in their ejection fraction. We had 67% of our patients achieve maximum up titration, i.e., full dose of ramipril or Entresto, 10 milligrams of bisoprolol. And we had over 100% on all 4 pillars. Now, the important time was what we then analysed. Well, what was the time taken for us to actually do this? And we tracked the total consultation and admin time to achieve this, and it averaged a total of, per patient, 40 minutes over the 8-week period. Now, if you compare that to not only a traditional, say, face-to-face, but just a telephone consultation, that was significantly less. When we then looked at our control group and saw what happened to them, clearly not in 8 weeks, nothing happened, but we then followed them up 3 months and 6 months later. 0% achieved either 4 pillars or maximum up titration, be it to what they were tolerated at all. So completely different. Next slide, please. So from that, we've won some NHS England money, and we have deployed this pathway across Barts. But moreover, this is now a pharmacy-led project. So we're now testing whether this can be done actually through our prescribing pharmacists who follow the same SOP. They're also given a crib sheet of what to do and dosed up titrate dependent on the readings that they get back. We take on 40 patients at a time at the moment, and they have 2-3 hour clinics a week to do this. So over a 8-week period, we're getting through kind of 40 patients, rapidly up titrating them. And again, we are working out the time, how long the effort, the efficacy, the difficulties, or any challenges we have, so that we can replicate this and scale even further. So that's just a whistle-stop tour about how, in a different way, I know there's lots of rapid up titration clinics, or some up titration clinics being started now, but the key difference for this was, can it be pharmacy-led? And can it be kind of done in an asynchronous manner, allowing for more efficiencies? Thank you very much.
Thanks, Debs. That's really, really interesting insights, and quite remarkable to see the positive outcomes that are being achieved within that 8-week period. Really, really showcases the effectiveness of this end-to-end approach. So